This is our second series of the Doctors Working in Israel series run by Adi. We are very, very excited to putting this on with our senior colleagues. Just a little bit about what we are. We're a community of doctors in Israel. We started about 3 years ago for English-speaking Olim doctors, those who've made Aliyah decades ago, to those who are just joining now and are coming in the next year or so. And we just provide a really great supportive family that can give you connections and networks and support and advice. And this is one of our new initiatives. We've got an in-person event coming up if anyone hasn't signed up. And we have our website as well. You can check things out. Before I hand over to Dr. Danna and Dr. Tanya, who've joined us, I just wanted to introduce I'm just debating which round to do this. Yeah, okay. I just wanted to that one of the questions that came up a lot was about Hebrew and what level of Hebrew you need when you're working in the Kupat, what's acceptable. So as of this year, they've just introduced a requirement to have to prove that you have not basic, like a fairly good level of Hebrew before starting work in Israel. The requirement is either you're after medical school and before internship, you need to prove that you have this level of Hebrew, or before getting your medical license in Israel. There are a number of different ways. I'm going to be writing a blog basically to explain how you can prove that your Hebrew is at this level that they require. There's an exam, there's finishing Ulpan until level Gimel. I'm going to put out a blog in the next few days with all the details there. So that's just basically, it's no longer possible to enter into the healthcare system here with very poor Hebrew, because you will need to have passed that basic level. And we're now going to hand over to Dr. Tanya. I'll just say personally, when I spoke to Tanya for the first time, I found out that she had basically been in my position making Aliyah after internship from England with young kids, or pregnant. She was pregnant, I had young kids, and feeling completely lost in the system. So for me, it was very inspiring to meet her. She's over 20 years in Israel. She's worked her way up to the head office of Maccabi. She's directing the whole telemedicine. So it's just very encouraging and very inspiring to see how far we can go, even if we show up and we have to push ourselves a bit harder at the beginning. So I'm going to hand over to Dr. Tanya Cardash. Thank you.
Thank you very much, Rivka, and it's an honor to be here. And Dana and myself are going to try and help give you as much information as we can. We're going to go through a very quick scheme, a very quick, brief each of us, and then we're going to answer your questions. What's very important here is at the end of the day, I want you to remember that generally all of the HMOs, all of the health funds are giving more or less, they're giving the same care. Everyone's based on the same basket of health. It's a bit like saying, in England or in America, which hospital should I work at? It depends on many factors. What's your interest, where you're going to live, what's more relevant to you. So it's not as it were, Dana and I are here together to help you understand the system. It's not, oh, come and join me in Maccabi, or come and join, Dana in Clalit. We're here basically to help you start your journey. And also, like any places of employment, it could be that one of the health funds at the moment looking for people in Bet Shemesh and the others aren't. So you need to always check out with both, because generally you need to find, where there's vacancies for you. Now, a little bit about myself. As Rivka mentioned, I made Aliyah 26 years ago now. I was newly married. I just finished my house jobs. I was accepted to a family residency in Maccabi. I now have, Baruch Hashem, 4 kids. My oldest one did the exam on Friday to get into medical school, into the 4-year program. So he's hoping that she gets in, because it's her dream, despite me being a doctor. And I haven't looked back for a moment. My last position, I was the director of the Maccabi Jerusalem and Shvela region, which is responsible for 700,000 patients for 5.5 years through Corona, through the war. And just over a year ago, I was brought into head office in Maccabi, and I'm in charge of all of the telemedicine, which is a very exciting challenge. I'm also in charge of integrating AI into the telemedicine system. So it's really quite exciting. Anyway, let me tell you a little bit about the healthcare system in Israel. Just very, very briefly. For some of you, it may not be relevant, but I think it's important you understand it. Okay? So there were four main health funds in Israel: Clalit, Maccabi, Ma'uchedet, and Leumit. They all provide service to the insured population. Anyone who is a resident in Israel, by law, has to be a member of one of these HMOs. And the important point to remember is all of the four HMOs give exactly the same treatment. So there's no postcode medicine, there's no differences between insurers. Each of them are legally required to give the same treatments, which are dictated by the healthcare basket. And there's an annual committee to decide which treatments are going into the healthcare basket. On top of the HMOs, which is the community medicine, you've got the hospitals. You've got the public hospitals, you've got private clinics and hospitals. We won't go into that exactly how they all work, but they all work in one big system where the HMOs basically feed into the secondary and tertiary care in the hospitals. And here the Ministry of Health sets standards, regulates health funds, and ensures that there's quality of care. Now, the primary care physician, the general practitioners, and the pediatricians here, they're generally your first point of contact into the system. They're basically the gatekeeper. They very much also encourage the refuah monat, the preventative care. Very important in Israel, the encouragement of mammograms and pap smears and screening colonoscopies, something which is very, very important to us. The primary care doctors also will refer the patients for secondary specialist consultations. It's very important to go via your primary care doctor, even if sometimes there are specialties which are direct access. Because, for example, going to see an orthopod with a knee problem, if you haven't yet done imaging such as an ultrasound of your knee, it's really a shame, because all he's going to do is send you off to do the ultrasounds and then basically come back and see him. So you need to use the system wisely and use your primary care doctor. We've talked a bit about hospitals, medications. Again, there's the list of medications covered, the same in all of the HMOs basically, and it's written in the healthcare basket laws. Now, quality of care. Israel boasts an average life expectancy of over 82 years, which is one of the highest globally. You've probably heard about it. I'm sure you know about Israel, a startup nation. There's high investment in medical technology. We're known in Israel as early adopters. There's a lot of research leading to very many advanced medical treatments. And generally, the patient satisfaction criteria in Israel are quite high. Challenges. There's a lot of challenges in the system. The system is managing with them. It hasn't, it's not got to the point where it's overwhelmed. But there are three things that basically are on the table as being issues. One is the aging population. There's an increased demand for chronic diseases. That's basically because we're treating our patients better. We're managing to cure people of illnesses or manage them chronically that we weren't in the past. Look at the breast cancer statistics. Look at also cardiovascular. Many years ago, a lot of people wouldn't survive a heart attack. Now it's a rarity that they don't. We managed to do cardiac catheterizations, cabbages. We've got medications to prevent recurrence of the atherosclerosis. So we're managing to keep patients alive longer. So we've got an older population. And connected to that, of course, we've got limited resources, because the money that there was originally to go round has to stretch over more people. And also there's always the issue between the public versus the private system. But at least in Israel, we haven't got a healthcare gap, that there are patients who don't have any medical coverage at all, which I know is a problem in some places, such as the United States. Very quickly now, I'll say, Rivka, I'll go and I'll say a few minutes on Maccabi, because that was a general introduction. Okay, Maccabi was founded in 1940. It was basically set up by a group of doctors who came from Europe, and they wanted to break into the system and set up their own consulting, which was more like what they were used to in Europe. Clalit was around a long time before and was treating the histadrut and the kibbutzim, But all of a sudden, this group of Anglo and German doctors made Aliyah, and they were used to running clinics from their home, and they wanted basically that model of services. So Maccabi's got 2.7 million members. It's got 10,000, over 10,000 employees. And there's also on top of that 8,000 independent physicians at Smayim. We'll speak about that afterwards. It's got basically 5 hospitals, the Asuta hospitals, only one of which is a general hospital, which is the Asuta Ashdod. The others are basically more like consulting rooms and elective surgery hospitals. There's a pharmacy chain. There's dental clinics. We don't really need to go into that. We've talked really basically about the major challenges. The directions are basically the continued investment in technology. We all have to be on top of things with technology because the technology is progressing whether we want it or not. So if we don't stay behind and we're not there, we'll just become outdated. And also important is to expand community-based healthcare programs. A lot of what's been going on in the previous years has been making connections with local councils, with schools. We all understand that if we want to prevent, as it were, the obesity, epidemic, it's to get involved with the kids, to get local councils to, to have areas where people can exercise, to encourage, healthy living. Again, I'll mention very quickly, and because I'm sure there'll be questions on this, the employment options for doctors. Hang on, I'm going the wrong way now. This way. Okay, so most people, I'm going to start with B. Most people in Maccabi are self-employed or independents. What that means is, let's say, as you can see, I'm sitting in my clinic now. As I work in my clinic, I am paid by Maccabi per patient I see per quarter. And I get payment for that patient, and I am then responsible for him or her, for all of their, whenever they need to come and see a doctor, I'm responsible for dealing with their results. And I'm also responsible for making sure that they do their management of their chronic diseases, or mammograms, pap smears, colonoscopies. I'm responsible for them from beginning to end. And the payments I get is basically per patient I see per quarter. Now, there is an option, but it's much less, that people are salaried employees. Now, generally, the salaried employees are more in managerial jobs. So when I'm in my other job as basically in charge of telemedicine, I'm not paid per patient then. I'm paid as a salary, as I've got a tech-en, I've got a, hours that I work, I'm 100% there. And we do the mitmachim, basically the residents, the trainee doctors, are also all salaried, and on basically for the first few years after the specialization finishes, they generally stay until they've got a sufficient patient base that we can basically let them be an independent physician. We do have a way of giving income support when someone starts to make sure he doesn't go home, as it were, empty-handed. But people generally like being at Sma'i because it gives the doctor a lot of flexibility. The Kupa can't move him from one place to another. They can't tell you when to go on Chofesh. It allows the doctor to decide maybe he wants 15 minutes to see a patient, maybe he wants 10 minutes to see a patient. So basically, he's his own boss and he can decide how to do things. Now, because basically you have this flexibility, it allows people to combine their job in Maccabi with doing a job somewhere else. A lot of people enjoy working in a hospital some of their time and in the clinics. A lot of people enjoy working in our Mokdei Chirum, which is our emergency out-of-care clinics. People basically also enjoy combining it with research, with teaching roles. Basically, everything goes. Now, something that comes up and we're asked often, especially by people who have come from America, is the issue of insurance, indemnity insurance, malpractice insurance. If you are employed by Maccabi or as an employee or as an independent doctor, Maccabi pays for your medical malpractice insurance, okay? That's very important to know. Now, there's two ways also to work in Maccabi clinics. You can either work in one of their clinics, as I do at the moment for my clinic, and I basically can, I pay overhead to the clinic every month, and then they worry for me about the secretary, the cleaners, the appointment system and everything. Or I can choose to have my own clinic, and then basically I pay the overheads and Maccabi doesn't deduct that. Some people like running their own clinic, others don't want the headache. So both of the options basically are there. Maccabi encourages doctors and medical professionals to participate in training courses. It's very important to us that doctors practice at the top of their license. We send them on courses to do home ultrasounds, on dry needling, on CBT. You know, it's important to us that every doctor finds his niche that he likes to do to give medicine. And again, you can also work in Maccabi in a management position alongside your clinical one. Innovations, basically, as I've written here, there's telemedicine. We have an application called Maccabi Doc. You can actually see it here. Oh, I'm sorry, it's jumped. You can actually see it here, which is great. Say I saw a patient in clinic now. I want to check later before I go to bed what happened with his x-ray, what happened with his blood test. I don't need to open the computer. I, as a Maccabi doctor, can basically see it online. We also have put in, we've got doctor-to-doctor virtual consults. Very, very important. I think Clalit has it as well. I can, for example, help my patient. I can decide, instead of me sending him to make an appointment to see an endocrinologist, I can send the question to the endocrinologist, get the answer back, and not have to send it to the patient, not have to send the patient to the consultant. We have smart sets that are based on evidence-based medicine, AI, and big data to manage common conditions. And also we have a 24-hour helpline for doctors, which allows, say I need an urgent appointment for one of my patients, an urgent CT, an urgent MRI, they will sort it out for me. I don't need to worry about it. That's basically in a nutshell, and I really ran through that. It's a little bit about Maccabi for you.
Thank you so much. And we'll go more into detail with the questions coming up. So I'm going to hand over to Danna. Thank you so much. Danna's a regional director for Clalit in my area, so she's a bit of a superhero. Are your slides up?
Yeah. First of all, thank you very much for the opportunity, Rivka and Bemet. Good job on this whole thing. I'll start before I even bring up the while I bring up the Matzaget. Exactly what Tanya said. There's no such thing that one kupa is better than the other. And this is true both for patients and for employees and for the doctors. I think when you choose your kupa, it depends on where you are and what it is exactly that you're looking for. And there's no wrong decision. All the coupon, all four of them, at the end of the day, they're looking out for the patient's best interest and for the doctor's best interest. How is already the question, and then everyone really will find out what's best for them. So we'll start. I won't get into everything. I mean, the health system Tanya already spoke about. I will speak about, I'm having technical issues. Here we go. So Clalit is the oldest health organization in Israel since 1911. We're the largest health organization in Israel, second largest worldwide with 4.8 million patients. And in terms of employers, we are the second largest employer in Israel after the government, and of course the leading employer in the health system with over 50,000 employees of salaried workers. Hang on. Perfect. In terms of the market share, we insure 52% of the Israeli population. This includes 1,600 clinics and 14 hospitals. In terms of our population, it's a wide diversity. 27% of the Arab sector, 5% of the ultra-Orthodox sector, 68% of our patients are under the age of 45. 14% are on the other scale, 65% and over. And then we have 61%, which is the Gen Y and Gen Z generations. The diversity isn't necessarily clinic-based, meaning we have clinics that incorporate all sorts. And I think it's the heterogeneity, it adds to the interest. In terms of the infrastructure, so we have 8 districts. Districts are essentially the community care, and they include everything, all the ambulatory care that we provide, and the 14 hospitals are listed here. In addition, we have Clalit Innovation, which is all the new high-tech AI, digital, which serves both the staff and the patients as well, and we have a huge logistics center. In terms of the hospital care, we have 8 general hospitals, 2 geriatric hospitals, 1 pediatric center, Schneider, 2 mental health centers, and 1 rehabilitation center. And an extensive community care, as I said, 1,600 primary clinics, over 10,000 physicians, salaried physicians, 13,000 nurses and nursing staff, 8,000 health professionals, pharmacists, administrative, and the numbers are huge. And very variable also in terms of the services with physiotherapy clinics, child development units, imaging centers, and over 500 pharmacies of the Clalit. Even the type of clinics really vary in terms of, we have primary clinics and rural clinics. And you have super large clinics with over 12,000 patients, and you can have very small intimate clinics with 2,000 patients. Pharmacies, we have newborn clinics that in Hebrew it's called Tipat Chalav, which is the nurses who do the follow-up on infants from the day they're born until 5 years of old, including following up on their growth, on their vaccines. We have pediatric centers, ambulatory pediatric clinics, mental health clinics, home care for patients at home with dementia or old age or debilitated patients. All sorts of specialty or consultation centers, women's health centers, occupational therapy centers, physiotherapy centers, child development centers, radiology centers, and occupational medicine clinics as well. So it's a huge variety. The way it's built really provides a one-stop shop that almost whatever you need to get done can be done ambulatory and in the community, which is a huge, huge, huge advantage. And I think it brings community medical care to a whole new level. In terms of the innovation in digital services, these are just a few of the services that exist for the patients. So we have a full-out Clalit app that allows the patient to do almost everything without actually having to come to the clinic. Online medical services for family medicine, pediatrics, dermatology, ophthalmology, menopause management, child development, dietitian, and these are all services that the patients can get from home. At-home services in terms of labs work, in terms of pharmacy, of having your medications delivered, and you have a whole set of digital medical equipment to do at-home care, including a home ultrasound follow-up during pregnancy. Tyto, which you see on the left, it's a home kit for a remote physical examination that you can either do with your physician or with an online service, 24-hour online service, and digital urine analysis. As Tanya stated, the online services that we provide for physicians with virtual consultations. We have a new system of CPI, which is really AI helping us do proactive and preventative medicine, also exists. That's as much as I can on Clalit and how it's built. In terms of career and employment opportunities, as I said, Clalit is the largest employer in health services in Israel. First of all, it's just Clalit Achad, one Clalit, based on hospital and community. And I think that's a very big advantage when we have so many clinics and so many hospitals as well. You can really custom make your own career path to suit your personal and your professional needs. And on the spectrum of working just in hospital or just in community, you can really build it whichever way you want and whichever percent you want and how you want to do it. And there's a huge amount of flexibility. And it's a huge advantage because there's some people who just prefer ambulatory care, but there, as Tanya stated as well, certain people, it's important for them to incorporate hospital, also to keep themselves up to date and to keep the variability in what they do. And in terms of the employment structure, and I think this is maybe the biggest difference between Maccabi and Clalit, is that the weight of salaried employees is much higher than the independent employees in our system. Um, the biggest benefit of being a salaried employee, and I think the majority of our staff, not only physicians, but all our staff are salaried. In terms of career development, you have a lot more options in terms of job development. I can say for myself, I'm a pediatrician. I started as a pediatrician, and then I slowly rolled into being a clinic director, and then I was responsible for pediatrics in my district. And today I'm a regional director. So the whole managerial pathway, for example, is something that's done for salaried employees. And then you have all sorts of professional trainings. Also, as Tanya stated, the courses she mentioned, and diabetes courses, and to develop follow-up for overweight patients. So you have all sorts of professional trainings that are done. Of course, you have the social benefits, sick days, vacation days, pension funds, which are all paid by the employer as well. As part of being a Clalit, you have, if you're insured by Clalit and you're employed by Clalit, then you have all sorts of benefits as personnel in terms of medical care, and you have reductions, all sorts of financial benefits. And of course, you also have employee benefits when you're part of the Clalit. You have all sorts of vouchers and holidays and all sorts of good deals. And you're part of an organization, you're part of a family, and it's really a long-term path. As an independent employee, you first of all have, in terms of financial, you have a greater, I called it immediate financial control in terms of your pension plan. Because when you're salaried, it's set by law, whatever you pay for your pension, and we pay for your pension goes. As an independent employee, you can decide that you want to invest less long term, so you can get more money now, or you can decide you want to invest in different ways. So the amount you get in your bank can change. You do have all sorts of tax reductions and deductions and reimbursements. And I will say that the hospital setting by us is only as a salaried employee, and you cannot be an independent employee in the hospital if you're just in the hospital. In terms of how the salary works, and this is true just for the community and hospital, it's a different system. Tanya stated that by Maccabi, the salary is based on how many patients you've seen per quarter. In Clalit, it's based on your patient file, meaning, and this is true both for salaried employees and for independent employees, it doesn't matter if your patients actually come see you or they don't come see you. You have patients who are assigned to you, they belong to you, and they're your patients, and that's what your salary is based on. So you can have the same patient come 10 times in a month, or you cannot come once in 10 years, and your salary isn't dependent on actually seeing the patients in person or by telephone. You can have no contact with them. And if you're in specialty medicine, if you're working consultation, it's also all sorts of different activities and procedures that you do, then they'll also go into the salary. When you're a salaried employee, the patient file, the patient load is based also on the quantity, how many patients you have, but also on the quality, meaning that you have benefits given if you have an older age group, 65 plus, if you have infants, patients who use the medical system more than usual, or if you have patients who are a lot more complicated with chronic diseases, and then we know that they make more use of the medical system, so then your pay is in proportion to that. As an independent employee, it's only based on the number of the patients, and we don't relate to how many their medical backgrounds. In terms of the hours that you actually need to work, when you're a salaried employee, the hours are divided in terms of frontal hours, where you actually see the patients, hours which are meant for administrative work, and enrichment hours, where if you're working full-time by us, then you get 4 hours a week to do some sort of enrichment, professional enrichment. As an independent employee, all hours are frontal work only. And the amount of hours that you're required to do as a salaried employee, they're variable because they're based on age, your employment seniority in Clalit, and the family status. And as an independent employee, it's only based on the patient file itself. That's, as in a nutshell, the system is kind of, it's not complicated, but it's variable, and that work. And I'll pass it over to Rivka for further questions, and then I think we'll take it in from there.
I would just like to say something. I would say how great an idea it was to have both of us, because as Dana was speaking, I'm like, yeah, I should have said something about title and whatever. I think basically you managed to get from both of us, because as I said, most health funds, they're all giving more or less the same thing. So you managed to actually get basically two people bringing to the table everything that there is. So I think that was a great idea, because almost everything she went through, I sort of like said, yep, I should have said that. I forgot to say that.
I was the same when you spoke, so it was perfect.
So I think it was a good idea, because it was two brains bringing things together. I will also say the models again, which is, and it's something that we're going to say as we go along. You have to speak to each Kupa, each HMO, about exactly what the terms and conditions are. Because, for example, when Dana was saying now for an independent physician, as it were in Clalit, there's no waiting waiting as in being paid more for a child under the age of 2 or an older patient or an oncological patient. In Maccabi, there is. Like the amount that you're paid per patient is actually adjusted. But, you know, the models, so don't take anything for granted when we come to the models.
Exactly.
You need to speak specifically to each HMO to see how it works.
Bottom line, I mean, I won't get into numbers and I'll let Rivka open up the questions soon, but bottom line, different, and this I can say, I've been recruiting doctors for 6 years. I don't think the differences, all in all, between the kupot are that significant. I don't think there's one kupa that, wow, they'll give you a ton of money and the other kupa will save on you. The differences
No, that's what I said. It depends where there's a vacancy at the time.
Exactly. But the differences are very mild, and I think the biggest differences are so individual and so personal and based more on what you're looking for than what they have to offer.
And what they're looking for, if they're looking for a doctor or a cardiologist or a pediatric specialist in the area where you are, as you know, it's very dynamic. If they've got someone who just retired or left or just opened a new branch, then fine, you know.
Brilliant. So we touched on a few of the questions, but what we've done is when people registered, they submitted questions and we've based the talk upon the questions submitted. So it's very practical. Like I said, some we've sort of gone over, but we'll go more into detail. And we've got spaces between topics for people just to ask any clarification questions that they have, and then we'll have just open question and answers at the end. But we'll try to keep up the pace so we have enough time at the end as well. And if you submitted a question and I didn't put it up, it's just because I tried to keep what was like the more niche questions I put to the side. But if there's time at the end, you can ask them. So obviously the questions are open to both Dana and Tanya. So someone who's just arrived, why should they, or they're still wherever they are, America, England, why do they start when they're looking for a job?
I'll say something first of all. Before you're looking for, I mean, first of all, when you're abroad, it depends where you are. It's very important to get in touch with Nefesh B'Nefesh that come to a lot of the English-speaking countries and do what's called medics, that they basically set up basically conferences and fairs, as it were, not really recruitment fairs, but fairs where you can come and you can meet the representatives from the hospitals, from the HMOs, and just as importantly, there are also their representatives from the health ministry, so you can actually submit your paperwork. So if you've already got a specialty in something, they will take your paperwork, scan it, and you will already get a letter from them explaining, because again, it's very hard to explain exactly which specialty is recognized from which place after how many years, but they'll take your documents and they'll give you a definitive letter before you've basically arrived in Israel, whether your specialization is 100% recognized, if you need to do another 6 months. So that's that first side. Another thing that I would say is so important, that if you can arrange a pilot trip or if someone can arrange a pilot trip, if you're already all here maybe, but if you're giving basically advice to someone back home, get them to sit for a few days in the fields that they want to work in. You know, we can always host and ask the patient's permission to have another doctor from abroad sitting with us. I very often do. If it's someone working in a hospital, they can very often shadow for a few days, to get a feel for what the work environment's that you're going to be going into is actually like.
I would also add geographical location. It helps because both as Tanya and I said, a lot of the job opportunities are based on where you'll be. So sometimes where you're going to settle is more important than where you'll find a job. And sometimes you'll take a job, you'll settle based on where you have the job opportunities. But it's a big factor. Although the distances in Israel aren't as great as in I know North America, so they're not as big as there. And I know that in the States and in Canada, the drive for 2 hours for a job is not a big deal. In Israel, the first thing I think we learn in Israel is, like a 30-minute drive or going from one city to the next sometimes can be an issue. So I think you have to be a bit more settled on more or less where you want to live or how much you're willing to commute when you start the search. So you have to first settle out, understand what's recognized based on your license, more or less your geographical limitations of where you're willing to work or where you're going to live, and then start.
Yeah, I agree with Danna completely. I also think the second part of the question, I think what she said is exactly right. You need to try and have, because you need to be in touch and say, I'm looking to move to the north, I'm looking to move to the south, I'm looking to move to Modi'in, Bet Shemesh, rather than saying, where have you got a position as a cardiologist? That's very difficult, for example. I think it's less relevant how the country is divided into districts, because that's something that we know, because you could come to live in Modi'in and we could have a position in Rehovot, which by us is a different district, but is actually 10 to 12 minutes up the road.
Exactly, and the Kupa, the HMOs divide our districts differently. So, for example, Modi'in and Rehovot and Clalit is in the same district. So it's also the way it's divided is less relevant. The significance of the districts is just you'll be dealing with a different managerial staff. That's the biggest difference. Everything else is the same.
Okay, brilliant. What is the hiring and interview process like? So they email the secretary, what happens next?
Well, I'll start by the way it works by us. The first step is meeting with one of the managerial staff in the area where you're planning to be. We start by I think in this day and age, the interviews they work both ways. We interview you, and I think the HMOs are no less interviewed by you. I mean, we also have to sell ourselves. So it works both ways. On my part, I can say that it's mostly understanding what it is you're looking for, what you're trying to build. I'm sure Tanya will answer the same thing. It's what you're looking for and how we can build it based on what we have to offer. And it's finding a middle ground between the two things. It's no longer how things were in the past. I think today everything's a lot more flexible, a lot more communicative. And there's no one set path. It's not like, oh no, you have to work full time in this place and that's it. We can tailor make any suits. It's mostly to understand what you're looking for, what your needs are, family needs, personal needs, financial needs, where you're willing to drive, and then trying to make it work.
Within boundaries, I completely agree. But sometimes people get very disappointed because their expectations don't really work in the long run. I'll give an example. If someone's, let's say, a cardiologist, and they're planning to be in America, let's say, for 2 weeks every month, we can make it work, because they can do a couple of clinics a week. But when someone comes to us and says they're a pediatrician or a family doctor, and they plan on being, and it happens 2 weeks every month in the States, then we can't do that, because we require our family doctors, both Danna and myself said, that basically you as a family doctor are responsible for your list of patients. As you can't disappear 2 weeks every month. Of course, you can go on annual leave. Of course, if you're on maternity leave, someone covers you. So very often there's a gap, which is why also it's very important to start the interview process even before you've made Aliyah. So you can actually do, as it were, a tium tzipiot, like a meeting of understanding the system. I also will tell you something that I changed to doing over the past few years, and it connects to what Rivka did. At the beginning, I felt when I was the regional director in Maccabi, and I used to interview the Olim, I would always speak to them in English, because I wanted to make them feel as comfortable as possible, and I wanted them to understand everything I was saying. And then at some point, we had some experiences that someone said, yeah, my Hebrew is great. there was no Hebrew proficiency test. We'd put them to work in a clinic, and then all of a sudden we'd find out they actually couldn't actually speak to a patient in Hebrew because they thought their Hebrew was fine, but it was high school Hebrew and they couldn't communicate. So the interview process, you should expect it to be in Hebrew. Yes, when you come to financial, if you've talked about general things, and then if you come to financial issues, it's very acceptable to say, I would like to understand the monetary things and go over to English. But you've got to expect us to test your Hebrew, because people are very often shocked about that. But if I was now, let's say, to go and live in England, Canada, or America, it would be absurd for me to think that I could work there without having a command of English. So, but that happens here. And I've had doctors say, well, I'll just see Anglo patients. But that doesn't work. And there is also, even though it's not blocked in the system and it's not, there's no hard grounds, rule about it, we do expect our doctors to write in the medical file in Hebrew, because it's not fair for other treating physicians who need to read your visit and read your referral letters to read it in a language which isn't their mother tongue.
Thank you. I don't know if you have anything else to add, but what advice would you give when they're looking for a position? How to approach?
First of all, it's the same advice for both. There's no difference. I think in the end, the person who chooses whether to be independent or salaries is based on their own personal preferences and priorities. I can say for all kupad, I mean, there's some kupad who make it easier or prefer salaried and others who prefer independent. But what you choose at the end of the day will be your choice and what's best for you. And there's no difference. I mean, in terms of how you're looking for a job, there's no difference in the way you should manage it, whether it's an independent position or salaried position.
Agreed, but there are some things where there is no flexibility and you don't have the choice. Like if you're joining a residency program in, let's say, pediatrics or family medicine, and actually here also, there's no even salary cutoff, because in the last year, there was basically all of the coupons basically came to the same point, that there is equal salary in the community I'm talking about for the residency programs. So here they will tell you you have to be basically salaried. But again, also for the same person, in a few years, you can often you can change. Like it's very common to take someone over as an Oleh and they're very nervous about an income and they want to know exactly what they're getting. So they start as a salaried position. And then at a certain point, we say, you know what? It's probably financially more worthwhile now with the number of patients you've got and your patient base for you to become an independent. And we can offer that and they can move. I started my position for many years in my clinic as a salaried position. And then at some point I moved over. So for the same person in the same clinic at different points in their career path, they can meet it that it's suitable, like the other side of the coin.
Exactly. You can switch. Once you choose a pathway, you're not stuck in it.
Precisely.
Things are flexible. And as you grow and you see, wait, this suits me more and this suits me less, the kupa is big enough to allow changes. So it's not a Catholic marriage. You have room, you have the flexibility. Also, as you grow into it and as you get to know the system better.
Okay, great. And we also have Dr. Eli Kramman who wanted to add something.
Yeah, hi. Thanks. I was in the webinar last week. First of all, thank you for hosting this. Is an amazing experience just to be here and listen. I will admit Danna is my boss, so I got to be very careful here. But I just want to add one thing that was mentioned last week, and those that weren't on the webinar last week should understand this. For U.S. citizens that are making Aliyah, there is a significant difference whether they are salaried as a regular employee or whether they're atzma'i as far as taxes go. So that's something that they need to take into consideration. There are those that say that even if you're an atzma'i, there's a way of getting around paying Social Security in the United States. But generally speaking, those that are atzma'i in Israel, if you're a United States citizen, you're going to have to pay Social Security on your salary. Whereas if you're a regular employee in the Kupa, you do not have to pay any. There's everything that you paid to the Israeli government as far as taxes and things like that, basically is it covers whatever you would have to pay in the United States. So there is a significant difference there, and that's something that should be taken into consideration.
Okay, thank you. Now, Tekin was mentioned before, and not everyone is aware what a Tekin is. It's basically a paid position that's available. So the question is, how available are these positions? Can you say a little bit about which specialties have more availability, different areas? Is it very variable? Can someone come and assume there's going to be a position for them as a family doctor or as a pediatrician? How does it work? And I'll just add that the next question was about Tekin Olim. So if you just it would be interesting to hear if those are also available. So specific positions for Olim doctors.
Dana, do you want to start? Do you want me to
I can start. Well, yeah. So availability, I feel like I'm already answering for both of us because I already know what the answer is. Essentially, the position, the availability is really based on your specialty and on your location. That's the bottom line. There are fields where almost always I can say there's a need, family medicine, pediatrics, but I can also say that there are areas, let's say Tel Aviv area, because you have such a high demand of doctors who want to live in Tel Aviv, that they're less available. So it's really dependent on what you do and where you want to do it.
100%. I'll just add here, listen, generally in Israel, we need more doctors. There's doctors who are retiring, but again, you can't be too fussy. You can't come and say, I am living in Renana, I am only going to work as a family doctor in Renana, because the Kupot will not put in too many doctors, so the doctors there don't have enough work. But if you're prepared to go out to the surrounding areas, there will be a position. There are some, Rivka, you mentioned, there are some specialties that we're desperate for people, generally psychiatry, geriatrics. I think they're two big ones, aren't they? At the moment, we're OBGYN, generally,
the five, OBGYN, orthopedics, ophthalmology,
OBGYNs,
dermatology.
But again, you'll get a job if you're not being too fussy and not necessarily. And I always say to people, you've got, when I give, let's say, one-to-ones and I speak to people, you have to know if you haven't set something up, it could take a year from when you're moving to when you are actually in employment. So you need to have provisions that you can basically financially live off savings or support yourself for a year, especially now with the Hebrew proficiency test that people have to do and the licensing as well. It might be people will come and it will take them far less. Again, if people are starting a residency program, it will generally be a lot less. But it could be easily 6 to 12 months before you're settled in a regular position. Even once you've chosen to take something on, or it can take a few months.
Sorry, I'm going to miss your brother's whole game.
So I think someone's not on mute. Again, the tkanim for Olim, it's something far more relevant for the hospitals than the community. It is b'ktana, but I wouldn't really go into that, What you really need to do is you need to start reaching out when you arrive. There's also a website called Doctors Only, which basically almost all of the HMOs and the hospitals put things on the Doctors Only website, looking for, postings and looking for positions. So that's also a good resource.
I agree.
Okay. And Tekin, this was another question. Are there my doctors take?
If I need a family doctor, I need a family doctor.
Exactly.
So then we'll discuss, like it's a logistics thing. A doctor's retired. I've got 1,200 patients without a family doctor. I then discuss with the doctor whether he wants to work as a atzma'i or whether he wants to work as a
Exactly.
So it's same. It's not really.
There isn't a difference. And I'll just add to what Tanya said before when she gave the example of Ranana. The reason why the Tekin or the options are limited, the same way that we said your salary is based on your patient file, whether it's per piece or how many belong to you, then if we put in too many doctors in one location, then everyone will just make less money. That's the bottom line of it all.
100%, yeah.
So the same limitation on tkanim is also meant to protect you so that you can also stay financially safe.
And are they still giving, like, are the government funding positions for him, or again it's
Less so
That's what I said, less in the community, more in the
It's
hospital.
more in the
More in the
hospital.
hospital.
Sometimes in the community, we'll reach out to the Misad Aliyah, Misad Klita, to see if they'll join in, but it's not a deal breaker.
Okay.
It's less relevant.
This was also, so if someone's looking for a job in the hospital, will you then fund a tech-in for them to then return into the community? How does
Depends
They
that?
want to do a residency.
It depends if it's something we need. For
Exactly.
example, if someone comes to me, I'm not now, if someone came to me when I was a regional director and wanted to do it in pediatrics, OBGYN, maybe eyes and ophthalmologist, if it was something, or dermatology, if it was something that I needed, I would put one of my, because each district has a certain number of trainee positions that we can train up. So if it's something I'm going to need afterwards, I'll say, I'll pay your salary in the hospital on the hitmachot, and then you come back and work for me afterwards. Normally it's 1 year by 1 year. So we can't really say yes, but if you want to do it in infectious diseases, I probably won't want it. It has to be something that I've got a need for in the future.
And I will add, if you're already a specialist and it's just a matter of incorporating hospital work and community work, then at least by us, because we have so many hospitals that belong to us, and it's not that the Clalit will fund your job. It's you can just work half time here and half time here. It's still the same Clalit.
Yeah.
So it's not really a funding, but you can be employed by the same Clalit and work in the two locations.
I mean, we'll do it also. I mean, it's slightly different because we use everyone else's hospitals other than Asuta. But let's say someone comes and the Histadruta Refuit, the Harry says that they need to do 6 months rotation in hospital, as it were, to get their full license in Israel. Then we'll do 6 months via 6 months. We'll say to them, okay, you know, we'll pay you from the beginning. You go and do your 6 months in the hospital. But then when you come out, then you have to be just with us, and you have to give us a certain number of hours, you know, normally for the first year or something like that, you know, because
so the coupon will help fund for in return that you're exclusive for them for an X amount of time.
For an X amount of time, which is very reasonable. And it's the same, actually, it's not just for Olim. Let's say if Maccabi sends me to study to do a degree, as I did through them in MHA, a Master's in Health Administration, and Maccabi's funding me in the time I'm away on the degree, then I do a year versus a year. If it was a 2-year degree, then I have to give them back 2 years, or I have to give them some money back. You know, the Kupa has to get something, as it were, in return for investing, you know, money in your absence hours from work.
We've just got 2 questions on negotiating contracts, and then we're going to open up for a little bit of clarification questions on what we've discussed already, and then there'll be some more submitted questions. So this is essentially how are contracts negotiated? Is there a lot of back and forth? How much room is there to move, to make demands? What would you advise as like someone sitting on the opposite side of the table? And this is just about what are the clauses that doctors should be most aware of when negotiating, and specifically for and this was a question that was asked quite a few times by doctors who joined the webinar.
Listen,
this is the most Israeli question.
I just want to say in general, and I'm sure it's true for Danna as well, we're not profit-based organizations. It's not if we pay someone less, anyone else is going to go home with more money. We're also very heavily regulated by the Ministry of Finance, okay? You can't really come and if I'm having a good day, I'll give you here, there. The salary that we give you is calculated on tables, on books, according to your experience, where you're living, as it were. We have things that are called Manak Peripheria. So if you're prepared to go and work in Arad, we can give you, as it were. It's the same with the Clalit system, I believe, and also with us. I can't invent
just clarify that, Tanya, because you just used some Hebrew words that not everyone.
Manak is
what did I say? What word?
Manak Periferia.
Manak. It's basically grants for agreeing to work in the periphery. So if, for example, you were to go and work in Arad, or you were to go and work in Kiryat Shmona, all of these things have to be approved by the Ministry of Finances. The Kupot are allowed to give you an addition to your salary for working in the periphery. If you live more than 35 kilometers from where you're working, you're allowed to give a travel extra money for travel. These rules are
car expenses.
It's not that I'm in a market situation where you can come and say, okay, just put it up by another 2,000 or this and that. It doesn't work like that. And also we've got nothing to gain by not giving you the maximum we can give you, because it's not like I'm going to go home with more profit if I pay you less,
About 3 years ago, Ministry of Finance put a ceiling on salaries in the community. And I think it wasn't total Wild West, but there was a lot more competition.
Yeah.
I remember I was negotiating with pediatricians where they told me offers they got from a different coupa, and I said, listen, take it, because there's no way I can never get to that salary.
But it's a lot
Times
better
have
now.
changed, and it's not like that. So we're limited. In terms of the salary, again, it's what I said earlier. The differences aren't humongous. They'll be very, very mild. And I think it'll be more in terms of the conditions and the type of clinics you're working, or how you distribute the hours, more than big salary differences. And
So
I think negotiation also depends on the patient file, on the patient load, on how many patients. You'll see this is at least for primary care. So there are also a lot of factors that can influence it, but it's all regulated. So there won't be, it's not a wild click. It's not an unlimited amount. Again, it's a public healthcare system.
Okay, thank you. I'm just going to open up for anyone who wants to ask any questions on what we've discussed so far. Like I said, we're going to cover other topics, but in the meanwhile, I'll just read out a few questions from the chat. Average number of patients per family medicine as a salaried doctor. Well, how many patients are listed by?
It depends on how many hours you're going to work. Normally, it's according to the number of hours. It's, again, I know in Clalit and in Maccabi, it's more or less the same figure. It's 100, and also at the beginning when someone's a new doctor and starting out, we'll give them less than afterwards. But again, it's not something that is worth getting into.
It's not black and white, and both Tanya and I, we can't get into numbers because there's a high variability, and not because we're trying to hide information, but we don't want to give false information. And I think to be more accurate, it's so personal that we have to understand what field you're in, where you're working, how many hours you'll give, how many years of experience, and only then can we actually get into figures. I know it's frustrating, but I would rather not get into something. Yeah. We can't commit to something because it is very variable.
It's also due to demographics, as Dana said. For example, in Bet Shemesh or Modi'in Elite or Modi'in, there would probably be more patients allocated to a doctor than, let's say, in Bat Yam and Cholon, where, a much higher percentage of the patients are going to be 70 plus and things like that. It's also due to the demographics, because we know roughly how many times patients visit a year according to their age.
Okay, thank you. And someone who's coming from military service, who's trained as a family doctor, is that considered beneficial? Is that a plus in terms of when you're looking to hire?
All experience is good experience.
Anything.
All experience is good experience.
Anything is agreed. Anything's good experience. If someone's come and what we also do, and I'm sure also in Clalit as well, is you fill in the gaps, because very often it could be, for example, someone who's come and done their specialist in the army as a family doctor. Like I had a case not so long ago, we actually sent him for a couple of weeks in a geriatric clinic and in a diabetic clinic, because he didn't actually know what to do with anyone over the age of 45, because even though he was, in the army, and there were people, as it were, who were on, like in what's Keva, within Keva, Dana, Rivka,
Keva is like
permanent
a permanent
position.
permanent
Permanent
army
position. You don't generally have the experience of treating the 70, 80, 90-year-olds that you would if you did your specialization in a community. But, you know, we're happy with anyone. We're not going to say anyone we want more or less.
Yeah, we're going to keep moving on because if no one has a question to shout out now, we're just running out of time. So the next question is about employment structure, and we've covered quite a bit of this already. The key differences, I think we've covered this already, right? Do you want to add anything?
Yeah.
Covered. Salaries, we've covered the salary components. Again, anything you want to add?
No.
No. Okay, VETEC was something which was discussed recently on our group and one of the questions. If you could just briefly
I could say for the Clalit, as salaried workers, VETEC is your seniority in the Clalit. The more years you work in Clalit, and this is what I touched earlier, then you get sorts of benefits. They're kind of steps based on age, based on how many kids you have. If you have young kids under the age of 12, I think, and on how many years you worked in the Clalit, and then they build the amount of hours you need to work as a salaried doctor based on these things. So at least in Clalit, that's how the seniority is integrated.
Maccabi,
other than that, it has no significance.
In Maccabi, there isn't a VETEC issue for salaried positions, but there is for Atzmai doctors. That, as it were, the value of your card, because I said before that you're paid per patient per quarter by card. Every year, or for the first and second year, and then for every 5 years that you've been in the Kupa, that basically your value of your card will go up. So, for example, I will be earning more per card than a doctor who starts in Maccabi yesterday. Okay? So it's actually completely the opposite, but we don't have it.
It's the opposite, but the exact same, because then in Clalit, you just need to work less hours for the same, so it works out the same thing.
Precisely.
Exactly.
At the end, we're going in swings and roundabouts. We're coming, again, it's where the fit is and where the job is for you. It's not, do I work with Maccabi or do I work with Clalit?
Just to clarify, Olim, they bring their VETEC with them when they make Aliyah, or they're starting at zero?
They have, by us at least, we have two forms of VETEC, of seniority. You have your seniority as a doctor, and you have your seniority as a Clalit employee. The benefits you get are mostly as a Clalit employee in terms of the amount of hours you do. The seniority that you have, or your experience that you have, it fits in your darga. I don't know how you say that. In what
is rank.
In your rank, in your salary. So it could influence. There's a difference there. It has some sort of I don't know if it's banding, but in the rank and the years of experience you have as a doctor, so it can influence the hourly pay, your salary base.
Okay, thank you. This was mentioned earlier that you mentioned about the pilot trip and you invited people, doctors, to come and hang out in the departments. Is that flexible whenever they want, however long they want? Okay, great.
It's normally you have to be in touch with the people and see. You can't have a pilot trip coming to Modi'in of 20 family doctors who all want to work, in Modi'in. I mean, just to reach out in time, and if it's something that someone wants to do, we can arrange it. We can find something to do. Again, it's normally for a few days. It's to get an experience because, it's purely observing.
Okay. So this is a question. A histaglut, I guess, is that what the official term is? Someone coming and wants a bit of time to settle in. Do you offer a sort of paid period when they're learning the system?
Depending on field and specialty and location, I can say now we have a doctor from a pediatrician in France who started working in our pediatric center, in one of our pediatric centers. She's now in a paid period of training. We're waiting for her to get into things, and then she'll join in the patient file. So it's totally an option.
And is that something that was agreed on, like when negotiating, when interviewing?
It's with her. Yeah, that's exactly. We built her pathway. We built the way she'll start and how she'll get adjusted in the community.
But I will say with that, that is the type of thing that I would like someone to come and sit with us for a few days for us to get a feel who the doctor is and how they're going to, how it's going to work. Because here you have to remember we're putting down, because generally it could be a month, 2 months even, we're putting money here on the table, not expecting them to do anything. So I need to get a feel that this is someone who's going to be a good fit for us.
Exactly.
Following on from that, so a doctor who's waiting, like you mentioned earlier about it can take a year until you're earning money. Is there any?
Yeah.
Sorry?
Maximum.
Generally, so if someone's waiting for their specialty certification to come through, which can sometimes take a bit longer, even with MEDEX nowadays, are there any job opportunities? Can they work as Rofeh Clali, do some locuming, any clinic?
I'll tell you something what I think about this. First of all, locum is in my mind not a suitable position for them to take at that point in time. I'll explain why. The whole reason that there was a period of what's called histaklut, now called hatama and everything, most of the doctors who make Aliyah to Israel, they know their profession there and their specialty inside out. The issue is that they have to learn how to work within the system. So if you're coming to the community and you don't know what to do when you've got someone with a suspected PE or a suspected heart attack or a suspected pneumonia, it's very, very hard for you to function. Where I would say that it is worth going to work if you are basically in your waiting period till you start somewhere, it depends. In Maccabi, you need to be a specialist to work. Other than the people who are in their residency training, we don't employ people who aren't specialists. But everyone in its great experience, people can work in the Terem clinics. They can pick up experience there. That's normally a very good place also to improve their Hebrew, to actually start being exposed to medicine. Some of the, there's also like Bikur Rofeh, where people can work in the emergency clinics before they're specialists. In Maccabi as such, if they're not on a trainee program, they can't work until they've got a specialist license, unless it's someone that we've taken on and we've sent him to the hospital to do his hatama or whatever till he comes back to us.
So by us, it's a bit different. We're more flexible. So we can employ someone who's not yet a specialist, but again, it'll be very individual based on what we're waiting for and how it will work out. But we try, I think, with all our efforts to find the right way to enable some sort of opportunity to start working either in the clinic or in the hospital, even while you're waiting for the paperwork, because we know as soon as the more time you have, it's like Tanya said, medicine, medicine. The issue isn't medicine, it's the culture. It's learning Israeli medicine and not medicine itself, and how to deal with the Israeli patients. So we try and find a way to enable work in the clinic until all the paperwork comes in. Again, seeing that the Hebrew is enough and seeing that everything else works out.
Okay. Thank you. I'll run through the last few questions and then we'll open up and try and be done before 9:30. This was also one that came up a lot. So in America, England, like general practitioners, family doctors are doing a wide range of procedures and seeing a wide range of specialties. When they come to Israel, they're able to continue doing that. For example, fitting IUDs, joint injections, and are they paid as specialists? Because specialists get paid per procedure. So how does that? Is there room for them to do that? And how does that work salary-wise?
In Maccabi, it depends what the procedure is. There are some things which people, especially coming from the UK, are very shocked about. That there is what's accepted in Israeli medicine. Now, in Israeli medicine, the dealing of IUDs and PAPs and things like that generally isn't dealt with by the family doctors, okay? Because there is a profession in the community of Refuat Nashim. So those things are generally out. Only in very rare situations where, let's say in a clinic in Kiryat Arba, which is by Hebron, do we give the family doctors a special permission to do that. There are many other things. If it's something which we have recognized that there are courses for family doctors to do, such as small nevi removal and IUD injections and dry needling. If there are things that are recognized, then if we can get a letter from the previous doctor's hospital where he was trained or something, saying that they say he's proficient in this procedure and he was supervised and he was trained for it, then we will allow them to do it. Now, the way that works is you are paid either as a salaried or as an independent physician. There's points that are added on to every time you do the procedure, okay? So if you were recognized to do a joint injection, you would be allowed to put on the visit a certain code. And then you just put in that you did a joint injection and you would be paid for whatever that procedure is worth. But it's a defined number of, and we've got a list, it's a defined number of specialties. And I believe the list is approved by the Ministry of Health. So it couldn't be in one kupar, it's one thing and the other. Like the kupots have a list of things which family doctors are allowed to do and pediatricians are allowed to do and so forth.
Thank you.
In
Sorry.
Clalit, family doctors, we usually don't pay an additional payment for different procedures. But again, as Anya said, it's variable. It depends on exactly what we're talking about and how many.
Okay, and there's just a allergy services doing skin prick testing. Someone's asking specifically.
Specialists
As
are
a family
paid per
doctor.
procedure. Family doctors by us don't do the skin prick testing.
No, because there's no, again, also, again, by us, it's by allergists, and there's quite strict criteria where you're allowed to do it, because you have to do it in a clinic where there's a resuscitation cart and there's nurses on duty as well. Because if someone has an allergic reaction, you can't be alone with a patient and things like that. But no, it's not something that's generally recognized in Israel for family doctors.
We mentioned earlier about research. I'm going to skip it for now.
Basically,
also,
in both cohort, there's opportunities to do researches and studies.
Exactly.
And in both cohort, you've got what's called Machonei Mekar. You have access to, there's grants to do it. There's time allocated to do it. You have access to analysts to help you. If that's their dream, both cohorts are very happy to do it, because in general, we very much encourage, there's a top heavy, there's an imbalance between the amount of research that comes out of hospitals as opposed to in the communities. So
and the amount of data in the community is insane.
The big data is insane. So all of us encourage that.
Exactly.
Okay. I'll just strengthen that. Like, I've been so impressed by how people have just taken a vision and just opened a clinic on whatever, like a menopause clinic, because that's their passion. And there's so much room here to really build something that you're passionate about. So, as well as teaching and academic and things like that. This is a question that came up a few times. Doctors who are coming here close to retirement and are struggling to get positions, or where do the kupots stand? Is there an age limit?
As salaried, we're limited by the government regulations of the age for pension. 62 to 67 for women, if I remember correctly, 67 for men. As independent, there's flexibility, but usually around 72 plus minus, depending.
Yeah, but I want to also add to what Danna's saying. Basically, a doctor who is coming and making aliyah over the age of 64, 65, he has to be realistic, and he should have discussed it with people earlier. It is unlikely he's going to get a job, because as Danna said, we have to salary off between already, depending on whether it's also, there's a gradual process now, because depending on when you were born, they're raising the retirement age. But again, already from the age of 62, we need to start doing assessments if we're prolonging someone's another year, yes or no. And it's not really, yes, we've got a bit more flexibility with an atzmai, but we're not going to take a doctor who's made aliyah at the age of 66, 67, to let him take a year or so to understand the system and start working. And then at the age of 70 say, well, actually, we have to retire you now. You know, because it's also not good for the patients that there's no stability. So I think, and as sad as it is, and I know now there's a lot of people who are coming over at an older age because their kids have made Aliyah, because they've got grandchildren here. But for those people, I would recommend there are really meaningful things to do as volunteers. The Army's always looking for volunteers. Hospitals very often are looking for volunteers. They're also looking for people who are medical liaisons who can basically help people translate and navigate this healthcare system. But I think you have to be realistic that if you're in the second half of the 60s plus, I think if you're over 60, 64, 65, you're not going to
It'll
be
be more of a challenge.
Thank you. I'm just going to skip support and we discussed that. So I'm going to there was one question I'll just read out loud about the electronic medical record systems in both Kupot. Are they the same? Is there any difference?
Maccabi and Clalit work with the same program, Clicks. There are a bit of differences between them. Everything is electronic. Everything. I mean,
but also it's actually almost irrelevant because there's a law which has gone into place as of last year, which is the Niud Meida Rafui, the transferability of patient information. It's actually one of the things I'm involved with in telemedicine. Within 5 years from now, all of the Kupot are actually meant to be working on the same system. They're actually just trying to decide in the Ministry of Health which medical record it's going to be. It's either Oracle or another one. Donna, maybe you remember the name of the second one. But a few years down the line, I think we're all going to be working on the same thing. One thing that is coming in already this year is there's going to be a standardized directory of diagnostic codes. That's already coming in this year for all of the
also what I can say is all information that's done in hospitals and ambulatory clinics are accessible, at least by Clalit, I think also for Maccabi, are accessible for the Clalit doctor. Like, I can see all the tests that my patients did in the different hospitals or lab works in the different Kupot. So if I have someone
we all have it. It's called a ton.
Okay, so by us it's called Ofek and now Ofakim. So it's different programs that we have access to all the information, which is, first of all, it's incredible. And it really allows for continued patient care, and we're not dependent on the patient to transfer the information, but we have access to it that we can initiate.
Yeah, we have it as OFIC in the hospitals for us, and it's ATAN in the community. It's a great advantage.
Someone asked earlier, I'm assuming it's no, but someone who's a doctor who's not working in the Kupa, who's working privately, can they access the Kupa electric records? No. Does anyone have any questions? I've just put here
a question that someone wrote at the bottom that I saw, which is less relevant because, again, we're government organizations. Someone wrote on the bottom, do the HMOs have private medical coverage for their doctors? Now, we're HMOs. We're all entitled by law to give public health care to everyone. Now, as someone who works in Maccabi or in Clalit, as a salaried or an atzmai, they very often will offer you to join in group programs that exist, as it were, for top-up insurance, which is, as it were, anything which is over and above what is in the health basket. But it's not like in America where you go and you get a job and they'll cover your private insurance. It's not the same way. I don't quite know how to explain it. Maybe Dana can better, Rivka. But
what Tanya said earlier, when you're insured by one of the HMOs as a physician, the insurance that we pay for covers, if you have a private practice, it will be covered. If you work for at least 30% as a salaried employee, that's at least for the salaried workers. Or no, also for the independent workers.
Okay, thank you. It was mentioned earlier about MEDEC, so just the upcoming dates. There's one in America and one in England. And to add that they're also doing the Hebrew proficiency exams in person at the events, which is amazing. So you can get that all dealt with before you arrive. This is our in-person event, just to put a plug. Come, it's going to be great. Question and answers. Before we finish, we've got 7 minutes if anyone wants to ask anything. I'll just check in the chat if there's anything we didn't cover yet. there was a question about flexibility of hours. How flexible is it? Salaried anatomy.
It's how long's a piece of string? It depends really on what you're going into. If you're a family doctor, or a pediatrician, we want you to do at least, let's say, 4 clinics a week because we want to have continuity of care. If you're a cardiologist or an orthopedic, then maybe you could work once a week. And again, it's a bit like how long is very, very individual. Again, I don't want to be awkward or, like Dana said, evade an answer, but I can't really give a fair response. I can only say that a family doctor and a pediatrician, we would want a commitment of at least 16 to 20 hours a week because we need continuity of care.
How you build the hours, it's I can say that we'll do the maximum. We'll do as much as we can to make it easiest within the scope of not ruining the patient care that we're giving and finding the balance between the two. But almost always we can find solutions.
One other question. How far in advance of someone making Aliyah are you willing to talk to them about job positions? Meaning, someone who's coming in the summer, are you happy to start having that conversation with them, or you want them to be on the ground with a medical license? Because there's this gap where people want to have a job to go to.
On it's not as much as how far in advance, but more as how well planned you are. Is your medical license recognized? Is the specialty recognized? And if you know your location, because as soon as you have these things, then we can get down to business. Without them, it's up in the air.
Agreed. We need to basically, we can't, if we've got a letter from the Misrad, they have from Histadrut Rofim or Misrad Abriut that your license will be fully recognized. So you need to do 3 months atama. Then we can start making negotiations with someone. We can't, if we don't know if their specialist is going to be recognized, I can't start negotiating on a position that they may not have the criteria to fulfill it, in the future.
Yeah, that makes sense. Any other questions from the crowd?
Rachel had a question before. Do you want to ask Rachel?
I do have a question. I apologize because this is a bit my scope of work is a bit niche. So I'm a qualified GP, but the majority of the work that I do is in hospital providing pediatric allergy and asthma care. And I can do this, comfortably in the UK. From the sound of it, it doesn't sound like that's set up to be able to be provided in primary care, but are there options for GPs like me to be able to get jobs within hospitals doing that kind of work?
You'd have to check with the allergy clinics. It could very well be that they would be prepared to take someone on. I don't think, as I said, the setting would be in the community, but it could very well be that they would be prepared to take you on to work in the hospital. Maybe Dana knows more about it.
It could also be by us. It could, because we do have allergists who work in the community. So it could be that we could work something out that if you're working alongside a specialist, then we can make it work. I'd have to check, but it could be something that we can find a solution for.
Anyone else? Okay. I knew that Tanya at least has been at work since 6 a.m. this morning, so it's 9:30 here in Israel. So we'll let you go home and go to sleep.
I just want to thank you for inviting us, and also Dana, I want to thank you. It works out that even though we've never really met, I think we did a very good show for them, and I think, listen, at the end of the day, if everyone feels positive about working in Israel and whatever, and please be in touch with us. Rivka maybe sends our emails, and Dana, Rivka, I'd love to meet all of you for a cup of coffee one time.
Absolutely.
So reach out
and I can promise you all, as you saw with me and Tanya, that after over 20 years in Israel, you become a lot more Israeli than you planned and you forget your English. So I guess it's a good sign.
Yeah.
Brilliant. Thank you so much for your time. I'm already getting loads of comments saying how helpful that was. Really, really,